Welcome to today's Explainer. I am absolutely thrilled to have you here because we're tackling one of the most fascinating and honestly most urgent mysteries making waves in AI news right now. We are looking at these highly capable AI models, the ones effortlessly passing bar exams and completely acing standardized medical tests. And we're asking a really critical question. Why are these brilliant systems suddenly failing when we put them in real-world medical settings? Well, the answer lies in a brand new benchmark that is completely changing how we view AI safety in healthcare.
Okay, let's dive right into this by putting ourselves in a very relatable scenario. Imagine walking into a clinic. You sit down, and before you can even finish describing how you've been feeling for the past week, the doctor just interrupts you, hands your prescription, and sends you on your way. You'd be terrified, right? There is no way you'd trust that doctor. Yet, as we're about to see, this is exactly the kind of overconfident, rushed behavior that today's top-tier language models are exhibiting when they're faced with complex psychiatric data.
Here is our roadmap for today. We'll start with the missing context problem, move into the Safe-Psych benchmark, expose the calibration gap, dig into why smart models fail, and wrap up with deploying AI safely. Section 1, the missing context problem. Let's explore the fundamental flaw in how the tech industry has historically tested medical AI. What's really interesting here is how this highlights a massive disconnect between the laboratory and the real world. For years, we've tested medical AI using standard benchmarks that operate on a deeply flawed premise. They assume complete information is available right from the very start. It's kind of like giving an AI an open book test where all the answers are neatly printed on one single page. But real clinical workflows, especially in psychiatry, they're stateful, they're incremental. Evidence accumulates over time through multiple patient interviews, lab results, and longitudinal tracking.
The unavoidable truth is that AI models expect everything to be handed to them on a silver platter. But real medicine just doesn't work that way. Psychiatrists almost never get a complete diagnostic picture in a single interaction. They have to gather history, observe symptoms, order tests, and constantly adjust their assessments as new data comes in. So when an AI assumes it has all the facts right out of the gate, it makes decisions based on a total illusion of certainty.
Section 2. The Safe-Psych benchmark. This exact problem led researchers to build a groundbreaking new tool. This is a real game changer. A new paper recently dropped introducing Safe-Psych. It's a sequential evaluation benchmark specifically designed to test how large language models handle evolving diagnostic uncertainty. And to do this, the researchers didn't just use standard multiple-choice questions. No, they utilized over 1,000 real-world psychiatric clinical notes. Crucially, they segmented these notes to simulate incremental evidence disclosure. Basically, this benchmark forces models into the highly uncomfortable position of making decisions under partial visibility, which perfectly mimics an actual medical triage process. At each stage of this sequence, the AI receives a tiny little subset of the clinical context and has to choose a path forward. And this brilliantly illustrates how the evaluation reflects actual real-world standards. The model has to output one of 3 psychiatrist-derived action labels. It can choose to diagnose, committing to a finding. It can choose to clarify, smartly requesting the missing context, or it can abstain, stepping back entirely when the data is just way too sparse. The model is forced to track information density across turns and decide what the absolute safest next step is. Section 3. Exposing the calibration gap. So, how did the most advanced models actually perform when put through this rigorous gauntlet? Well, the data is shocking. Over 60%. Just let that number sink in for a second. Across most evaluated models, researchers found an under-abstention rate exceeding 60%. This means that more than 6 times out of 10, these highly intelligent models confidently generated diagnoses despite missing critical clinical context. Instead of asking for clarification, they just guessed. They rushed to a conclusion, completely oblivious to the fact that they simply didn't have enough data to make a safe medical decision. The crucial point here is understanding the difference between 2 totally different concepts, capability versus calibration. The models we have today have incredibly high capability. They perform beautifully on standard, full-context medical exams. But this study proves they completely lack calibration. Calibration is the self-awareness required to recognize when clinical data is insufficient to make a reliable conclusion. It's the AI's ability to measure its own uncertainty. And right now, that ability is severely lacking. And the consequence of this overconfidence is exactly what you'd expect. When models suffer from under-abstention and diagnose too early instead of asking for clarification, they get it wrong. The Safe-Psych evaluation confirms that premature diagnoses are consistently less accurate than on-time diagnoses. The models are genuinely trying to be helpful, but by rushing the process, they're actually providing much lower quality and potentially very dangerous outputs.
Section 4. Why smart models fail. To truly grasp how to fix this, we need to shift gears and dissect the underlying architecture.
The researchers summed it up absolutely perfectly with this quote. They learn to map partial patterns to complete labels. They do not learn to model their own ignorance. This gets to the very heart of how autoregressive models actually work. They are optimized for token prediction. Their underlying loss functions reward them for producing definitive outputs based on statistical patterns they've seen in their static training datasets. They aren't built to pause and think, wait a minute, I haven't seen enough tokens to know this for sure. They just confidently spit out the most likely completion, completely failing to model their own ignorance.
Now, you might be wondering, can't we just write a better system prompt? Unfortunately, trying to fix this with simple prompting creates a really predictable and frustrating trade-off. Standard prompting gives you that premature commitment and overconfidence we just talked about, but if you try safety-aware prompting, telling the model to be extra careful, it just breaks in the opposite direction. It shifts the errors toward excessive abstention. The model basically stops diagnosing entirely and refuses to help, rather than learning to distinguish between, I have insufficient data and I just need to ask a few follow-up questions. Section 5. Deploying AI safely. This brings us to the most practical and important part of our explainer. For all the developers tuning in, here is your actionable playbook derived directly from the Safe-Psych findings. First and foremost, you must treat the LLM as a pattern-matching engine, not an autonomous doctor. Fine-tuning alone is not going to solve this uncertainty calibration gap. Second, you have to build safety into your architecture by implementing explicit uncertainty thresholds right in the application layer. Third, when the input data falls below that predefined threshold, route those requests immediately to a clarification protocol or a human review. And fourth, please stop relying on LLMs to self-regulate their confidence. They simply aren't built to do it reliably.
The researchers also laid down a very clear red line for development teams. If you run your model through a sequential benchmark and its under-abstention rate exceeds 40%, it is definitively not ready for clinical decision support. That is the hard boundary where the risk of an uncalibrated premature diagnosis just becomes way too high for safe deployment in a regulated medical environment. Okay, let's move to and see how this builds into an actual testing framework. To catch these calibration gaps, developers must build a stateful evaluation architecture. Step 1, segment your clinical notes into thematic or chronological chunks. Step 2, feed those chunks incrementally to the model context window without resetting the state. Step 3, extract those specific action labels, diagnose, clarify, or abstain at every single step. Step 4, compare the AI's choices against the ground truth of what a real human psychiatrist did at that exact stage. And finally, run full information baselines in parallel so you can quantify exactly how much the model's performance degrades when information is hidden.
I really cannot emphasize this enough. Static testing masks calibration gaps. Relying on single-turn inference, where the model sees the entire patient history all at once, is simply insufficient for healthcare. If you want to build truly safe clinical AI, you absolutely must build evaluation pipelines that simulate real-world data latency and incremental disclosure. It's an incredible technical challenge, and it leaves us with a profound question about the future of medicine. If an autoregressive AI fundamentally struggles to model its own ignorance, if it cannot reliably learn to just say, I don't know when the data is incomplete, should it be allowed in the exam room at all? It is something every developer, researcher, and healthcare provider needs to carefully ponder as we move forward. Thank you so much for joining me on this explainer today. Keep learning, keep questioning, and I'll see you next time.